I'm Rachel, and this is Pam. So I'm the reimbursement person, and she's the dietitian. And so we're just kind of opening it up to you guys, totally informal, just roundtable discussion, anything that you want to talk about, reimbursement related. This session is specific to enteral, but we can talk about parenteral too if you want to.
It is enteral.
Yeah, but it's fine. I mean, there's so much crossover anyway, and a lot of this, especially some of the reimbursement stuff, kind of applies to both. And obviously, we have a pretty small group, so so anything that you have questions about, or anything that you have concerns about, or any, I guess, even experiences that you've had, or troubles that you've had, challenges, it's just open discussion, basically. Who wants to go first?
Well, I don't know about anyone else. Y'all are awfully young. But I am going to be having to do Medicare.
Okay.
And
Are you a
that's-
consumer?
I am a consumer.
Okay.
With TPN.
Okay.
And I'm ultra concerned about the financial outlay. I've told my husband for the past 2 or 3 years we needed to get divorced so that we could be divorced X number of years prior to the onstart of Medicare. And I won't bankrupt him or
Yeah.
us as
Right.
a couple. So those are my concerns. I don't know, and I don't think I'm going to get good guidelines from the folks at Medicare, or in trying to choose, the right Medigap plans.
Yeah.
And what to look for and all of that. I'm just petrified.
Well, the first thing that I would say is it's really good that you're even thinking about it, because a lot of people don't until all of a sudden they're on Medicare, and then we're trying to do everything after the fact. So I think you're already actually in a good place, the fact that you're thinking about it now. What is your time frame on when you're going to change over to
Every
Medicare?
year that, at the end of this year, my husband's company will decide if they're going to continue with his health insurance.
Okay.
If he doesn't, then I already have to be on Medicare Part A because
Okay.
I'm medical disabled.
Okay.
So I will have to go to big Medicare or whatever.
Whenever his
that-
insurance.
Yes.
So, have you started the conversation with your current provider yet about whether you qualify for Medicare, and kind of started the qualification process at all?
Heck no, I didn't
Okay.
know we had to qualify.
Yep.
Holy smokes.
So Medicare has specific guidelines on medical necessity guidelines that consumers have to meet, Medicare beneficiaries have to meet in order to qualify for parenteral nutrition.
I see divorce in there.
No, you don't have to go there. Michelle is with our company.
Oh, there you go.
And it's okay when we a friendly one.
Yeah.
So this is from just a provider perspective?
Yeah.
So when we recognize that you're going, or you tell us that you're going to be transitioning to Medicare, we work with your physician to gather that documentation to prove clinical necessity. There's 7 different criteria that you can fall under.
Yeah.
So we
And
will
I would
help you.
I would recommend kind of starting that conversation now,
Yeah.
because I don't know how long you've been on parenteral nutrition, but there's probably, it probably isn't a new diagnosis. So at least start gathering.
You meet one criteria.
Yeah.
You have to be on for over 90 days. So
Right.
You met that criteria.
Yeah.
It's
Permanent
done.
impairment, check. But that way, you're not, you've got kind of all your ducks in a row. I mean, obviously, it sounds like you've got a good provider that knows what they're doing, and will help you through that process. The Medigap, to address the Medigap policies, so Medigap, Medicare Supplemental Insurance, will cover what Medicare covers. It'll cover the coinsurance, which is something to have, it's something good to have, because your 20% coinsurance with Medicare is going to be substantial for TPN. Whether it's a good plan, a not good plan, they're all pretty much the same as far as what the benefits are that they cover, to my knowledge. Again, that might be something that you can kind of work with your provider to help you navigate which plan makes the most sense. But it's always important to keep in mind that those Medigap policies are not going to cover any services outside of what Medicare covers. So if you have, and I don't know how likely this would be, but if you get like a line infection and you need IV antibiotics or something like that, Medigap plans will not cover that. Correct.
Why? That's
Because-
stupid.
Yes. So that's where you could have coverage for the actual drug piece under a Medicare Part D plan.
Right, so I'm gonna have to go to, how many Medicares, there's A. So I have to go to A,
Yep,
I have to get B,
yep. And then Part D,
and then, is that extra?
yes.
What's, Medicare A and B, are those?
So A is like the hospital plan. B is all of the other kind of outpatient services, DME included, which is where your parenteral nutrition would fall. And then D is for prescription drug benefits.
Okay, so that's extra.
Yep.
All right, so then I have to find a company that is going to cover my $40,000 worth of medical supplies every month, my medicine.
Yep.
Yeah, that's just great. See, I told you.
Well, I think you're,
Most of our medicine should be covered.
yeah, most, Part D, yeah.
Right, so they should be covered. There's a donut hole, there's like a gap that you're gonna have to.
Yeah, there's a
certain
coverage gap.
threshold, but that's diminishing over time.
And that's another thing that you can look at is the Part D plan. So the way that Part D plans work,
So I get one shot every month that costs about $12,000 to $14,000.
okay, so that
So I'm
will,
already out of the donut hole,
Yeah.
in and out of it within one 24-hour period. Right?
most likely, yes.
And then what happens after that? Is
So
it
then you
covered?
have a small, so basically what happens with Part D, and the Part D plans, there's a lot of variety with those plans. So there's an established base coverage that the plans all have to meet. And then, but they can have better coverage than that depending on the plan. So what happens is you have a certain copay up until the coverage gap. Once you hit the coverage gap, you're responsible for a couple $1,000s, $2,500, $2,700. Once you pay that out of pocket, then you go back to having coverage at a smaller copay usually. Usually it's like 5% coinsurance or something like that. Or maybe just a copay after you've met the out-of-pocket maximum.
Yeah, but even if it's 5%, I mean,
Yeah.
it's 5%.
It depends on the drug, it depends on the formulary. I mean, there's tons of different variables. But that might be, I mean, if you do have specific medications that are chronic medications that you're going to be on all the time, that's one thing that you can, when you're evaluating plans, is kind of have your list of medications and figure out what the best plan is. And a lot of retail pharmacies and
They'll do
even
that
home
for you.
infusion pharmacies will do that for you. You can kind of give them the list of your ongoing medications and they can do that evaluation for you. Which would be important because you don't want to get into a plan and then have, I mean, plan formulators can change and things like that, but you don't want to get into a plan and then have your medication be not covered, outside, non-formulary, something like that. You want to be aware of.
But they can't change the formulary during your contract year, can they?
Not during the contract year. Usually it's just like a once a year
Okay.
formulary change. It looks like you're going to have some work to do with your provider.
I'm emailing her dietitian and branch manager right now.
Oh, good.
Get on the call and start talking. So, we'll work it out.
They'll help you through it.
So what is Medicare E, F, and G?
There isn't. There is Medicare. Yeah, that'll probably be coming. There is Medicare C, which is the Medicare Advantage plan. So that's Medicare Part C is Medicare Advantage. So that's managed Medicare. So that's where you as a consumer would sign over your benefits to a managed care plan. And they administer your Medicare benefits for you. So,
My son has that as he's a special needs adult.
okay.
How is that, would a Medicare Advantage plan be anywhere beneficial to me?
So this is where, I mean,
That's a big question.
that's a huge, that's a That's a big question.
Depending on what state you live in, depending
Yeah.
on what's available, there are lots and lots of plans, and you have to lay them all out. We were joking yesterday, like, I wish there was an app for that.
Yeah.
That you could compare them apples to apples,
Yeah. It's
because
tough.
that can be time consuming, and you might be limited on the provider you can go to, on the doctor that can write the prescription for your medications, on the hospital you can go to, on the special center out of state you can see. You have to look at all that to make a decision. I mean, straight Medicare is probably the easiest, but you might have some advantage looking at another plan. It's hard to say.
Yeah. So the way, and just to add on to that, the way the Medicare Advantage works is similar to the Part D, which is that the Medicare Advantage plans are required to cover at a minimum what Medicare covers, but they can have different benefits outside. They can cover additional services outside of what Medicare traditionally covers if they choose to do that. So, and I think I mentioned this yesterday, but I have had patients that did sign on to Medicare Advantage plans because they were routinely getting services that were not covered under traditional Medicare. So they were parenteral patients, pain management patients that were getting IV hydration.
I mean, hydration's a really good example.
Hydration,
Medicare does
IV
not cover
antibiotics.
I'm sorry?
Medicare does not cover hydration.
Right. So, there's no benefit for hydration. There's no benefit for IV antibiotics. Again, the drug piece would be covered under the Part D, but
Is hydration considered a drug?
well,
Is
just
that
the
gonna be covered
just the
under
bag
D?
itself, just the actual bag. That's it.
So the bag's covered under D, but the tubing
Yeah,
to
the
get it to your
supplies.
pump
Mhm.
is not covered.
Correct.
And that's what could be potentially covered by the Medicare Advantage.
Correct. And usually
Does that
that's
make sense?
billed as a per diem.
Makes sense. They can give you part of it, but not everything is covered.
Yeah, it's just a partial benefit under Part D, just for the actual medication itself.
But I can have all of these Medicares if I want, is that correct?
Yes.
I can be A, B, C, and D. I can have,
You can be.
no, it'd be C and D.
You can have C and D, or you can have A, B, and D.
A, B, and D.
Yep.
Okay. There's no E for all of the above.
No. Not yet. It's always possible.
So it's you just have those multiple choice.
Yeah.
C, D.
Just always go with C. No, just kidding. That's only with multiple choice. If in doubt, no.
So with C though, I mean, she's gonna have to look at all the different plans.
Totally, because
Sometimes with C, they actually are, depending on the state, and it
Totally.
actually is more beneficial because they say they follow Medicare guidelines, but not exactly.
Exactly.
They have more liberal benefits for coverage for your Part D drugs.
exactly.
So there may be a benefit to considering specific C plans, managed Medicare plans for you compared to
Yeah.
going the A, B, and D route.
Exactly. I mean, it totally depends on your particular scenario. What types of therapies you're used to getting, whether you meet the Medicare qualification for parenteral nutrition, all of those different variables, and then what the plan covers, and what the out-of-pocket and costs are for the plan.
And what about colostomy supplies and things like that? Where does that fall under Medicare?
That would fall under Part B, and I am not an expert on colostomy supplies and how those are covered, but I know that those are covered under do you know about colostomy?
Not that much, but it'd still be 80/20, I believe, because
Yeah.
it's a durable medical equipment supply.
And is there a supplemental for DME?
There are, so Medigap or Medicare supplemental plans,
That do include DME?
yes, that will cover the 20% coinsurance for the products under the DME benefit.
Like ARP is the typical one,
Yeah,
one of the-
AARP
if you're over 50, you can buy that to take care of the 20%.
But the thing about that is if B doesn't cover, it's an uncovered therapy, and Part D is a boy, then the 20%.
Like it wouldn't work on hydration.
Right.
Yeah.
So like hydration, is a great example.
Yeah.
Part B does not cover hydration, therefore your supplemental will not pick up
Right.
What if
So-
they pick up 80%?
Then they'll pick up the.
They'll pick up
Then
the
they'll pick up the
20%.
20.
Which, I mean, again, for the TPN, 20% can be $30 a day. So, I mean, so it's, you know, if you're covered under Medicare for the parental and you're going through standard fee-for-service Medicare, you know, that would be something to take a look at. Otherwise, the out-of-pocket amounts can. And the benefit under Medicare of the 20% is not like, you know, commercial insurance plans where there's a maximum out of pocket. It's a flat 20% always.
All the time.
Yeah.
And that's the same thing that I understand with Medicare Part A. Every time you go in the hospital, it's an $1,100 deductible, whether you go once or 10 times during the course of the year.
Yeah, I don't know.
I-
There's no cap. There's no cap on that copay on Part A. Unless it's changed within the last year. That much I did know because that concerned me, because I have Part A now, but I have Blue Cross Blue Shield, so that picks that part up.
Yeah.
Yeah.
But when I don't, then if I'm an inpatient, every inpatient stay, not emergency room or 23-hour stay, but a 24-hour stay or longer is an $1,100
Fee.
yeah, deductible.
Yeah, I
And
don't.
there's no cap on it. That was the thing that was a great concern, because that was a change when they changed the Medicare stuff years ago. They made no cap on it.
Interesting. I don't know.
Yeah, I don't know for sure about that.
I'm,
And I hope I'm wrong, but I haven't seen anything to the contrary with that.
do you, so for the folks that just came in, I'm Rachel. This is Pam. And we're just doing open forum. We don't have a presentation or anything. We don't have any formal guidelines or anything. Just any questions that you might have or any topics you want to bring up.
I have a question.
Sure.
I have Medicare as my secondary insurance.
Okay.
And soon Medicare is going to become my primary insurance. And
Okay.
commercial insurance is going to become my secondary
Okay.
insurance. And my concern is I have enteral services and I have infusion services.
Okay.
When I get sick, that's the only time I have to worry about, like TPN or anything like
Sure.
that. But mostly it's hydration.
Sure.
In which, as you know, Medicare's primary is not going to cover it.
Right.
But no one has been able to give me straight answers what happens when Medicare is my so-called primary insurance and my commercial insurance is my secondary insurance. The home care company keeps telling me that the commercial insurance is most likely going to be picking up everything, but I don't really know because
Yeah.
Medicare doesn't pay for anything. They're telling me everything's going to remain the same except for the fact I'm not going to have nursing services. But I don't know because I keep being told that whatever mirrors Medicare mirrors like the commercial insurance, but I really don't
Is
know.
what is the cause of your insurances to flip? Can I ask
My
you?
whole disabled adult dependent, and my mom's will be retired.
Okay.
And
Okay.
that's gonna be the flip. And
So-
her age, it's gonna flip.
And you are going to remain on her plan, but she'll be retired, and so then they're
Yeah, exactly.
then they're
She retires
changing
in-
the other way.
So they'll be paying at 20%, so that Medicare will be like 80%.
So have you gotten information about so sometimes when people retire, the plan changes and it goes to a different type of plan. So my main
Your retiree plan.
a retiree plan, which, so one of the things that you want to validate, and you may have to do some of this homework yourself or your mom, is, basically what those services are that you're receiving are still going to be covered when the plan changes.
And sometimes there's options.
Yeah,
Like
sometimes
from
there's
a government
options.
agency,
Yeah.
there might be 3 options: a PPO, an HMO, and a.
There'll be a PPO. My
It-
mom works for the state. So
Okay, so it'll still be a PPO
yeah,
plan.
we have a PPO, but they said everything will be exactly the same. And they keep
Okay.
making statements that we have like the right to not like cover these services and bounce it back to Medicare. And, like, that makes me very nervous.
Yeah.
Yeah, I was gonna say, get that in writing, what
Yeah.
what the coverage is, and that they're not going to just supplement Medicare, that
Yeah.
they're a true secondary, we call it, true secondary, standalone almost.
Yeah, and one thing you might almost want to do is take some of your current EOBs with the actual procedure codes. Your mom, there might be an HR person or something at her work, and kind of work with them. Some of the federal plans, no, so this is different than state plans, but what I have seen is that they're following medical. More recently, some of the federal plans in some of the states are mirroring what Medicare.
That's exactly what they said.
Yes.
That's the term that they use.
So I would try to take those procedure codes, the J codes, the S codes, and try to validate that those will continue to be covered under your new plan. Even though it's going to be a PPO with Medicare as primary, things can get a little sticky. Now, if it's something that's completely statutorily not covered under Medicare, like hydration or antibiotics or something like that, or pain management or anything like that, typically those I haven't seen have been a problem.
But you could run those codes by them.
But you could definitely run those codes and should run those codes. Where the federal problems have come up is if Medicare is denying it as not medically necessary, then the Blue Cross plan is denying it now. But again, that's federal, totally different than your situation. But those can be things just to, just kind of be aware of, could be a problem. But
especially if you're on TPN and you kind of go on for a month or two and then you go off.
If you're on and off services, that's where it gets hairy.
yeah, or if you're
that-
not getting it at TPN every day, or
Then it can be difficult to meet the criteria like we were talking about.
I know what you're saying.
okay.
But it'd be nice if you didn't meet the Medicare qualifiers, knowing that the secondary would pick it up.
Is it a Blue Cross plan? Do you know?
No, it's New York State government employees plan.
Okay. Trying to think if I've had any problems with them. None come to mind, but I think probably the most important thing is to take those procedure codes, work with the HR person, work with the plan, contact the plan, try to get a conversation going and validate that, and try to get whatever you can in writing.
Okay, so to get those procedure codes.
From your EOB, from your explanation of benefits is the best place.
You said she had to do J and
Yeah, J codes, S codes, B codes. There are different codes associated with different services, and there typically are going to be what's called HCPCS codes. In the Medicare or in the medical coding, billing coding world, there's CPT codes, which are typically procedure codes, and then
Like my J codes, like I got like Zofran, like my Zofran.
exactly. Yep.
Yeah, like those
Yep.
codes, my J codes.
So depending on what kind of service there's a code set associated with that that
what's the
is
code
used for
set
billing.
associated with parental?
So parental can be either B codes, like B as in boy, or per diem codes, S code, per diem codes, depending on the payer that you're billing to. And those are in my,
The BS code.
the BS,
Yeah,
yeah.
there you go.
Yeah, they're in my presentation, so,
The only website.
yeah, exactly. So, yeah,
I'm sorry, I'm not a consumer.
that's okay.
Thinking I'm a person.
So the explanation of benefits you would get a copy of when the claim is processed. So that, yeah.
Way more.
So, yeah. So a claim from the insurance company. So a claim gets billed to the insurance company or whoever the third party payer is, and then the payer sends a copy of what information is, what codes they processed, basically a copy of the claim, sort of, or the procedure codes that are on the claim to the consumer.
I get a minimum of about 8 pages of EOBs.
Yeah.
I get like a big fat envelope of them.
Yeah, and
Yeah.
they're like this long each, so each page front and back has, every little code
Yeah.
associated with every little thing that everybody charges for everything. that, those are the DOBs that people get every month.
I'll definitely look for that. Thank you.
Yeah. Did you have a question?
I do have a question, and actually, you guys really helped me yesterday. So I do a lot of blenderized home tube feedings for my patients.
Okay.
I educate a lot of people on that.
Okay.
And it used to not be a problem that if we weren't ordering like tube feeds, that we could still order supplies.
Okay.
So Medicare does not cover supplies without a tube feed order.
Correct.
So I used to not have problems with private insurance.
Okay.
And now I'm starting to have those problems with private insurance.
Where they're not covering the
Where they
supplies
will not
either.
cover the supplies either
If
without
blender-
without a prescription for the tube feed. It doesn't matter if I tell this person it's blender. I think everything.
Okay.
And so it ranges between like $9 and $30 a day for
Right.
the supplies.
Yep.
And these are people that are willing to buy a $500 blender and buy all the foods, and people grow their own food organically, like they're doing all this stuff for like their ALS patients,
Sure.
or their special needs child. I mean, they're putting in a lot of commitment, but that
Yeah.
$9 fee is the line in the sand they're not going to cross.
Yeah.
And I don't want to tell people, well, maybe you should appeal this to your insurance company if you don't think that's a worthy use of their time. So do you have any insight on that?
I know blenderized foods is, I mean, I'm hearing it more and more and more, so it must be even becoming more popular. I can't say that I have a lot of experience with trying to get supplies covered in that scenario, to be honest with you. I mean, the interesting thing is that a lot of the times the insurance will only cover the supplies. So
Yeah.
they don't even cover the formula in the end anyways.
Right. So
I would say only if they say they follow Medicare criteria or they mirror it.
do you find that more private insurance companies are following Medicare criteria since the change in the Obamacare open market?
No, I haven't seen that. I mean, the only trend that I've really seen with the Affordable Care Act stuff is just that a lot of the Affordable Care plans don't provide coverage for DME. But I haven't seen anything
I
else.
haven't seen, if they're, they might be, if they have Medicare as their primary and you're sending it on to the secondary, it might be the code that Medicare is putting on it with the denial, because there's different reasons to deny. There's, I don't know how many different ones, but they can deny it for medical necessity, they can deny it because they say the diagnosis codes aren't right, they can deny it for simply because it's not covered, which would probably be the one that they'd be getting, and then if the secondary mirrors Medicare, they're going to deny it.
Right.
And it may just be that I need to just prepare people that if we're going to do blenderized feeds, there's a very real possibility that the supplies are not going to be covered
Yeah.
as well. I think it's more that people get surprised, and I've had
Sure.
people get like a $1,200 bill in the mail 3 months after they start doing blenderized feeds.
Yeah.
Yep.
And you can't do anything about it at that point.
Right.
I didn't prepare them for that.
What is your process internally for verifying benefits up front, notifying patients of coverage, things like that?
So that's right. So people,
Yeah.
I think, I know that the company that I work with most frequently always, they tell people these things. I just don't think people understand.
Yeah.
And I don't know if they're not, like, I don't know, do they have to give you an exact dollar amount per day of what that would cost you, or just tell you that it wouldn't be covered?
They have to give you the amount.
Yeah, they should be giving you at least an estimate, and especially if you're going to be billing the patient or consumer privately, then they should be giving them a dollar amount. I mean, patients shouldn't necessarily be getting surprised with a $1,200 bill 3 months in. I mean, that,
See, I kind
In-
of thought that was, like, I thought that was weird. but
Yeah.
I do have a lot of patients that have selective hearing.
Sure.
Selective reading.
yeah.
So-
And sometimes, I mean,
A lot of times
Yeah.
we're overwhelmed.
Yeah.
definitely.
We're getting it, we don't.
Yeah, definitely. I mean, yeah, especially on initiation of therapy or something. I mean, there's like a million different pieces of paper that they're going through and, all kinds of different things that are being talked about. And it could just be that they didn't totally interpret it at that time as well.
And so you have to sign here, sign here, sign here.
Yep.
And then you have to fax this back within 24 hours.
Exactly.
If you're concerned about getting your supplies, that's not always.
Yeah. But the thing that I would say, kind of going back to your question as far as if it's worthy of their time to appeal, I mean, from my philosophy, it's always worthy because honestly, you're never going to impact change or anything like that unless unless that happens. I mean, it depends on the appeal process and
If
how.
it's an exclusion.
Yeah.
If they say, for instance, in your situation, if Medicare doesn't cover, we don't cover, then there is really,
Yeah,
you
it's-
can talk till you're blue in the face,
Yeah.
and it's an exclusion.
Yeah,
But doesn't, well, I know, every state has an insurance commission, is that correct?
it does.
And
Yes.
that's who you can ultimately appeal to if it's something that's excluded, to get it included, and that these are the reasons why, and you can start if you want to,
Yeah.
start a campaign for people like us to get those things included.
If it's a specific item that's excluded, for instance, they'll say we'll pay for supplies, but we don't pay for formula. You're right. There might be a way to get that now put as included. But if it's a broader thing, like if Medicare doesn't cover, we don't cover.
It's yeah.
Who regulates Medicare?
CMS and essentially the federal government.
Yes.
Yeah.
Yeah.
Congress.
And there has been no changes since what, 1991 or something?
Yeah.
Literally no change.
Yeah. Anybody else? Any challenges that you guys are seeing out there? Yeah. Yeah.
Those getting covered by insurances? I have had some patients that have done that. It took more than 2 years of appeals, of letters of medical necessity, of using other formulas and not having good results,
Mhm.
of hundreds of pages of fax documentation. It's getting covered.
I think
And the Good Hope is extraordinarily expensive to pay for it.
Yeah.
Now, they will send you some samples. They'll send you like 8 days worth of samples, which is really nice, because then you can kind of, and then if you go and see your medical provider, like that's actually how I got one patient covered, is we got her 8 days worth of samples, and she tried it, and she said how great she felt, and we talk about that in all of the notes we have for the patient, and that's that, with the letter of medical necessity plus everything else for the last 2 years. And finally got covered.
Which pair was that?
I'm sorry?
Which pair?
So they have, he has Medicare, plus he has, Kaiser Gold, was like for Medicare, and
Yeah.
Advantage Plan, and Pennsylvania.
Okay, so that gave it some flexibility probably. Both of them are 4.9, B4149, which the requirement for that specialty category requires that you have an allergy to a regular standard formula. And so that's the difficult part to prove for most patients, is that unless you have an anaphylactic event from a standard formula, that's the way the guidelines written, and they're not going to veer from that.
So
Although
was it
some of the-
Geisinger that ended up picking that up then, or did Medicare end up paying for it?
I think the Kaiser Gold ended up paying for it. I can't tell you for sure.
Okay.
I'm not following
I think
it.
a great case study
Yeah.
to follow over the next 12 months.
Yeah. I've never seen a Medicare Standard plan cover it. In fact, we've gone back to look at the other 4.9 formulas for coverage, and we could not find one in the past 8 years, I think. We looked.
Right, so
Complete, yeah. I mean, what you can do is just accept the lower amount that Medicare gives you, and usually you come out fine. You know, that if the patient needs it, that's fine. But the costs of the two blenderized formulas are about double, I think, of complete.
And what about other commercial insurances besides Medicare? The other question that I got, was there wasn't a process just for commercial insurance.
And they approved it.
And they approved it, and it came from a specific, we had to change who delivered their feeds to them, because I guess the Good Hope has some people that work with them.
Okay.
specifically. So their whole reason for me they were working with was not willing to assume the cost of keeping that in stock for them, but there was another television company not
Yeah.
too far from where they
Gotcha.
was willing to deliver.
And then they did it.
Must be some serious
pouring.
rain happening.
Yeah, it is. Pouring.
What else, I guess from the provider side, is there anything that you guys are seeing, trends or challenges or anything like that from your end? The audits, yeah.
Definitely trends, and each region is different, so Region D is out west, and they have the largest portion of the US, and they seem to sort of lead the charge of what they want to audit. And many others kind of follow suit, so
Yeah.
for a while, we were having a lot of audits on pumps.
Yeah.
They wanted to see evidence that the patients failed on other,
Oh, really?
failed denied, or a lack of failed trial on other methods, lack of evidence in that.
Even if like the patient has a J tube and,
They want, now what they're asking for is the procedure report to prove that a patient is a change.
oh, really?
Yeah.
Oh,
Which I respect it.
Yeah.
I'm
Yeah.
fighting Medicare, just like everybody in this room, so
Yeah.
I see both sides of it, and I respect it, because I think there are a lot of errors made in billing, and so
yeah.
Yep.
it's the right thing to do. They have certain guidelines, and they tuck it into their prosthetic device benefits, so
Right.
it is what it is, and we have to play by the rules and be respectful of the purse and the money that's in there and spend it
Definitely.
appropriately. So, you have to be creative sometimes clinically for patients who don't meet a certain guideline to find a clinical alternative for them so that they can't afford it. It's different than HEN, because in some cases it's not covered. It's horrible. It's not something that you're making the worst move to. That breaks my heart hearing you even say that, so. Smooth that out, but, so the audit activity, they'll do cert audits, so they find certain areas where they see common errors
Mhm.
made in billing, and then they'll focus on those types of errors, and, the way I explain it, and it makes sense to me, right, because here's how it works. We have a series of numbers, they're HIC codes, which is the type of formula and the different feeding methods, and then we have ICD-9 codes, and we have 100-calorie units. That's how we bill them for the calories that we provide, and it's all sent electronically. And then Medicare sends us money, so we send them numbers digitally, and then they send us a bunch of cash, essentially, right? Sounds good. Right, so we.
And they send it pretty fast, usually within a couple
And
weeks.
so what I say is when they deny a claim, that's really the beginning of a conversation. That's when we actually furnish records that we've been pestering the providers for. And, before you come on service, we're gathering all of our evidence in case they deny claims, so that when the conversation begins, because it will, we have something to provide in that conversation, which is evidence that
Why wouldn't you provide all that in the beginning?
it's just not.
They don't require it.
Yeah.
They want it. Yeah,
The-
there's no avenue for it.
Yeah.
So only during that time of the conversation. if there's a
It's
denial.
based on trust
Yeah, it
that
really
the
is.
doctor ordered it and we're going to cover it.
Guidelines, and we're submitting claims in good faith. There's no authorization. They don't give us off. We don't ask ahead of time, do we have permission to bill you for this? Are you gonna pay us? And ahead of time, we don't clear the trail, so to speak. We know their guidelines, and we bill in good faith, knowing that we know what we're doing, and they're gonna check up on us from time to time. So they're doing a lot more checking up,
Yes.
Yeah.
and for good reason.
Yes.
Because there were a lot of companies out there that were not doing it well.
Yes.
Not doing it.
And you say these are new changes.
The guidelines have not changed, but the way that they check them has changed.
And there have been some, yeah, I mean, and there have been some new guidelines implemented as far as,
The Affordable Health Care Act had one of the 10 titles in the act, or whatever they're called. There's 10 things. One of those is the recoup of fraudulent billing.
yeah,
And so there's a whole department for that now under the Affordable Care Act. And they are responsible
Yeah.
for bringing in a certain X amount of dollars every year in fraud prevention. So I think the audits were spurred because of that too.
well, and the audit, one of the main reasons for the audits increasing or continuing at a certain level is because they identify what the denial rate is. And so, like, for example, enteral nutrition therapy, I mean, depending on the region, depending on the quarter, the denial rates are usually still in the 70 to 80% range, or 60 to 80%. I mean, I just saw one for Region A, it was still at like 83% or something like that. And the reason for that is...
And you can get those worked out. It
and
doesn't
you can,
mean
yes.
you're not going to go back
Absolutely.
and give them...
It
Yes.
is.
Yes.
And it's but the reason for that typically is that it's the technical details that are not being met. So it's, you have your requirements for your detailed written order, for example. So you have to have an order before you can bill for services. And there are technical components that have to be on that order. And if you're missing one of the components, it's going to show up as a denial.
So what happens if one of those technical components is not on the original order, but they correct it a month later? Does that mean everything within that month is going to be denied until the doctor writes the correct order? Yeah.
Yes, because you also can't, the other thing that you can't do as a provider is you can't sort of go back in time. So if I had an order that did not include all of the components that I needed to have, and I went ahead and billed a claim because from that order, and I get audited on that claim, that claim is going to be denied. Yeah. They'll take the money back. And so then if I kept billing on that order for months because I didn't get the audit right away, then really probably every claim associated with that order is going to be denied.
You have to, and you just eat it.
And
that's been the downfall for providers
yes.
since the computer age, because then you go back and add a paper copy to a chart, and you can't do that on the computer as easily.
Well, in the end, you still have to have a signature, and whatever the signature date on the order is.
Yeah. Either way, it's not legal.
Either way, yeah.
I'm not saying that they were doing it legally by
Right.
back
Right.
dating
Right.
or back sticking in
Right.
the chart, but that's,
Right.
I know
Yes.
that that's what was done.
Yes.
I know it was.
Yes. Yeah, so it's those technical components that are, but that's one thing that, and part of why I wanted to mention, where I mentioned it yesterday when I spoke, is that I think it's really important for consumers to understand what the provider's requirements are to a certain level, because I hear from consumers sometimes, why do they need to talk to me before every shipment? Why can't they just send the product? Why do they ask me? Why do I have to tell them how many cans I have left, how many bags I have left, before they will send me product? And the reason for that is that it's a Medicare requirement, and that's something that has kind of changed or became more structured within the last couple years.
It's always been in the requirement, but now they're auditing. We have evidence of a conversation that illustrates the days on hand, what they call days on hand, and we have to know down to the can.
Yeah.
How many years,
Yeah. And that was really implemented as a cost savings, B, a patient protection, because what was happening very routinely in a broad sense was that providers were shipping based on the order every month and not checking that the order is still valid, not checking the consumer is still using the product based on the order. There's going to be flexibility, especially way more so obviously with enteral than parenteral. But some days you might not go completely according to the order. But yeah, there were definitely instances where consumers had just tons and tons of supply at home because it was just continually being shipped. So, that wasn't appropriate.
And then it shows up on eBay for sale.
Yeah,
exactly. There's a whole
downstream effects from
yeah.
that. So I think that, to me, that was a beneficial thing that has happened. But it does require the consumer to have a conversation with the provider before it can be shipped. And if you still have 3 weeks of supply for whatever reason, because you were hospitalized or something like that, you may have to have another conversation with the provider, a little bit closer to when you're actually going to run out of, that would be for enteral, or both, but before they can ship. Because it's not just that the provider has to have a conversation with them and document that conversation, but it also has to be within a certain time frame. So the provider can't call the patient a month before the product needs to be delivered. It has to be within, 10 days? So if you still have 3 weeks left, for whatever reason, they're gonna have to call you back within that 10-day time frame. Because Medicare will check all of those dates. And if it's outside of that, then,
Well, they'll check it by asking us to send in the paperwork, the
Right.
thing that you sign when the delivery driver gives you the thing and you sign it. They'll ask to see a copy of that.
and then also potentially a copy of the progress note or the
Oh,
notate.
the conversation.
The
yeah.
conversation, the documentation of the conversation.
Yeah.
And again, that isn't anything that can be backdated. So the provider has to.
Or they will
document
physically
that.
walk into the branch office and say, I want the paperwork. So you have to, it has to be there physically in the branch. So, and that has happened.
If there's a case where the provider didn't provide the correct order and 3 to 6 months go by and all of that's denied, and we signed a paper in the beginning that we will be responsible for expenses not covered by blah, blah, blah,
You would never get a blanket statement like that.
Right.
The provider can only have you sign for specific costs, and then they have to list specific reasons that are in the Medicare guidelines that are reasonable. Yeah.
So they
We
would
never do a
have to
blanket.
give you would have to be given what's called an advance beneficiary notice. And unless they have that, you would not be responsible for that.
And this wasn't recently, it was probably 2 or 3 years ago, that we did receive bills that were denied. And we were told because we signed some form that said that we would assume responsibility for denied services, we had to pay those bills.
And that was part of your commercial insurance.
Okay?
So that's a little different. So commercial insurance, there isn't the ABN, there isn't the advance beneficiary notice.
You're right. Every one of us signs that when we go
Yeah.
to any doctor. Yes, I'll pay for whatever my insurance
so
does, and that is a
unfortunately,
blank.
unfortunately, so there are protections under Medicare for patients, for consumers, Medicare beneficiaries, from getting billed for services that they weren't aware weren't going to be covered. In the commercial insurance world, there aren't those protections. So when you do sort of sign your life away at the beginning of service, that's really up to your provider on holding you accountable or holding you responsible for that. But they are, if it is denied, they are within their rights to bill you for that if you did sign that. Anybody have anything else they want to talk about? How about competitive bidding? Has that had any impact on anyone's lives in the room? Not really. Yeah. Other than that, it's the worst. Well, it is a very interestingly structured program.
When I had issues with it, I called my company and made them make me switch back to a company that I
You did,
with.
yeah.
So how often do they competitively bid for a area?
Every 3 years, yes, yes. Yeah.
Because I felt like I had just gotten down for referrals for that competitive bid area, and now that competitive bid area
It has changed again.
Well, I actually like better, but still,
Oh,
it's-
that's
you
good.
know what I mean? I posted for facts everything.
Yes, so it's every 3 years. Yep. Yeah, that's been an interesting development, but at least the initial, the really early bidding was tough. Was really
confusing
messy, but I think that some of the issues have been worked out now.
My area was one of the last ones to get hit, thank goodness.
Oh yeah.
Ah.
Oh, okay. Yeah.
So like people who competitively bid,
Mhm.
do they have to meet certain
Yes. The bidding process is pretty extensive. I'm sure you had experience with it, as did I. There's all kinds of certain criteria that have to be met. They have to be licensed. They have to, there's all kinds of,
You have to send in your annual budget. You have to
yeah,
send
your
in,
financials. The
yeah,
companies have to meet certain financial requirements and things like that. The bid itself has to be a valid bid. You can't bid, crazy low numbers just to try to win a bid. I mean, it has to be, what's the word I'm looking for? They have to be able to validate your actual, what you're bidding with, prices and things like that. I'm trying to think what round is coming up now again.
4 or 5.
It's like there's rounds and then it's a rebid and then it's, but enteral continues to be. They have not included parenteral yet, and I don't know. I hesitate to say that I don't think they will, but
It's not the volume that enteral is,
Yeah.
so it's probably going to be a while
Yeah.
before that happens.
and
My
it's
company got indirectly affected by inflation because they were trying to get us to switch like all of our infusion. The company tried to like harass us into doing.
oh yeah. So external infusion pumps are included, which now they're going to be excluded now coming up, but that's maybe where that fell into, where you were getting a pump for other services.
They
Yeah.
said, well, it's just logical if you're going to have enteral with us, if you switch your infusion to
Oh.
us too. So it kind of was like an indirect kind of thing.
Gotcha.
Like my insurance company. And they kept saying, well, we're not going to like really want to service you. You're not going to switch to us. It was like a nightmare.
Yeah.
And it kind of fell in that kind of like.
Well, you should always know that, I mean, obviously your insurance company has some impact on the providers that you can choose,
Yeah.
but it's also always ultimately your choice on provider.
Yeah.
So I think that's really critical that you are aware of that. That patients, consumers always have the right to choose
I kind of found that.
and
out
not be
during the
bullied
process.
into using a certain provider or something like that, which unfortunately does happen sometimes.
Yeah, I didn't really know that until I kind of did my homework to find out that even though they have that bidding, that you kind of have your choices about where you could go.
Yeah.
And a company can't tell you you have to use this.
Oh yeah. Ultimately, you always have a choice. I don't know how we're doing on time here. Oh, it's 3:40, so we're right up against the end of the session.